LRA Posture Analysis by Javen Valeria, Eileen Torres, John Laminero, Hope Rodriguez.
Hello everyone, this is our LRA posture analysis, and today we'll be talking about 3 different types of postures. So the first posture we'll be talking about is the one on our left, the perfect posture. This is where good alignment of your body is balanced and not under strain, with the head, shoulders, and hips in a straight line. Now our next posture we'll be talking about is the one in the middle, the upper crossed forward head pattern. And our last posture on our right we will be talking about is a lower crossed, increased lumbar lordosis anterior pelvic tilt posture. In this video, we will be going over all 3 of these different types of postures. To start it off, our first posture is a perfect posture. From the side view, we can see that the plumb line passes through or slightly anterior to the earlobe and the acromion process, and then it keeps going inferior to the greater trochanter. Then it will go more inferior to the midline of the knee, and then it will lastly go inferior to the lateral malleosis, also known as the ankle. This posture shows neutral spine curves and efficient weight distribution. Now on our skeleton, we see the plumb line moving superior to inferior from the earlobe to the shoulder, which is the acromion process, to the greater trochanter of the hip, and then it keeps going inferiorly to the midline of the knee and to the lateral malleosis. And also we see that on the posterior view of the skeleton, the plumb line goes through the midline of the skull, inferior to the spinous processes. Then it goes inferior to the center of the pelvis, our gluteal cleft, and it splits the legs evenly. This shows how the scapula is equally spaced from the spine. And we can also see that there is no hip, knee, or ankle deviation from side to side. To summarize, on the side view, we see it goes from the ear inferiorly all the way to the ankle in a straight line. And to summarize the posterior view, our spine and pelvis are centered, and the shoulders are very symmetric down the scapula and our hips. Next, we'll be talking about our forward head posture.
With our first patient on this lateral view, we can already notice that his posture is nowhere near perfect. His ears is anterior to the plumb line, and his increased thoracic kyphosis, which leads to his shoulders and thorax, anterior to the plumb line as well from the lateral view. This shows us that he has a forward head posture that leads to weak and tight muscles of the poor posture. Now we go to the anterior view, where we can already notice that his clavicles are sloped forward. Next, we can also see his rounded shoulders, which shows he has a weak pec minor and that his scapula is very protracted. Now on the posterior view, we can actually see more that his shoulders are way more rounded, showing that the middle trap and rhomboids are also weak. This also shows us that his serratus anterior is also weak, which will control the upward rotation of the scapula. These weak muscles will show likely pain patterns, which could be frequent tension headaches, and in layman's terms, his shoulders and neck will be very sore. Our goal as the PTA is to increase those muscles that are weak and to loosen up that tight tissue. A plan for this patient could be chin tucks, supine seated and standing, also seated band retractions. We could also add in serratus punches and thorax extensions with the foam roller. This will all fix our patient's forward head posture. The first exercise we will have our patient do are chin tucks. First, we start with supine chin tucks to keep our patient's spine supported. This will allow longer holds with less strain on the neck. Supine will be able to isolate those deep neck flexors a little more. This will reduce the forward head posture and keep his head superior to his spine. This will also help the neck muscles such as the SCM suboccipitals, the upper trap, and the levator scapula. Next, we transition to seated chin tucks. This is a more real-world position. This is because gravity will load against your spine, and it'll train the weaknesses because you are not supported by the floor. These will work on the flexors more because they will not rely on the supine position to keep it stable. This will also train his posture endurance. Last, we will have our patient do standing chin tucks. This is perfect for walking, running, exercising, and turning your head. This will be the most difficult of the three positions for chin tucks.
You must prevent shifting, swaying, or anything else. The head must be controlled over the whole spine, which makes it the most challenging. A simple explanation would mean that chin tucks strengthen these deep muscles that pull your head straight back and stabilize your neck. While stretching, the tight muscles contribute to forward head posture.
Exercise 2 will be scapular retractions, which will relax and depress the scapula.
This will improve his rounded shoulders because the scapula returns to its neutral stable position.
This will strengthen his rhomboids and middle trap. This will help with less slouching in his posture.
The rounded shoulders shows that he has a very weak pec minor. A simple summary would mean that seated scapular retraction helps rounded shoulders by pulling the shoulder blades back to normal and strengthening these rhomboid and middle trap. It also stretches the tight chest muscles and it builds endurance for maintaining good posture.
Another exercise will be his thoracic foam roller extensions. This will reverse the excessive kyphosis on him. This will reduce exaggerated flexion and have the mid, back, and upper chest lengthen and stretch. This will have the neck create better alignment, and this will also reduce his rounded shoulders. Muscles activated will be the multifidus and the erector spinae group, and muscles stretched will be his pec major and minor and the upper fibers of his rectus abdominis.
A simple explanation would show that this combination improves rounded shoulders and slouching and forward head posture. The extensions strengthen the thoracic extensors and improves thoracic mobility and rib cage position.
The last exercise we have our patient do is serratus punches. This is one of the most important exercises to fix his rounded shoulders.
The serratus anterior is a key stabilizer for the shoulder blade. So when the scapula sits in a poor position, that encourages slouching when the serratus anterior is very weak. These punches will strengthen that. When the serratus is weak, the shoulder blades wing outwards and slide into protracted, unstable positions, which generally creates the rounded shoulders.
This also helps the scapula with arm movement and keeps it flat against the thorax. A stronger serratus will keep it in a more stabilized position.
To summarize, the serratus punches help the rounded shoulders by stabilizing the scapula and the rib cage. It prevents forward tipping or winging, and it supports correct shoulder position. It also corrects forward head posture by allowing the upper back to extend, and it reduces upper trap dominance and helps the neck reposition over the torso. Your neck will no longer have to push forward to compensate.
To fix that forward head posture, we had him do chin tucks. We also had our patient do scapular retractions for that rhomboids and that middle trap. We also have them do thoracic extensions with the foam roller to complete the neck immobility and rounded shoulders. And now our last exercise we had our patient do was serratus punches for the weak serratus anterior, causing those rounded shoulders. To conclude, some likely pain patterns or patient complaints, also known as how they may describe it, can be dull aching at base of his skull and his posterior neck. Also could be frequent tension headaches that start at the occiput and can radiate to his temples in layman's terms. Also, some pain patterns can be the mid-upper thoracic pain between the scapula and the shoulder girdle will ache, and clicking or stiffness can be from the overhead activities. Our patient may give us some complaints by saying his neck can get tight when he works at his computer for an hour or sits for an hour. Also, they could also say how they have headaches and sore shoulders after long periods of on their phone. And lastly, some motions that are likely difficult for our patient can be cervical flexion or chin tuck with control. Also, overhead reaching, which is from poor scapular upward rotation and rotator cuff control. And lastly, preferred positions of our patient can be standing or reading with his head forward and his shoulders slumped. Relieves stretched deep neck flexors in his short term. And may keep his hands in his pockets or forearms flexed to reduce scapular retraction demand. And this is why he is in this horrible posture.
Hi, it's Eileen. I am going to break down what lumbar lordosis is and what anterior pelvic tilt is as well. Let's start off with lumbar lordosis. This refers to the natural inward curve of the lower back. A small curve is normal and helps with shock absorption and spinal alignment. But excessive lumbar lordosis, which as you can see in the picture, means that the curve becomes too deep. When this happens, the pelvis usually tips forward. The stomach may appear more pronounced and the low back muscles stay tight and overworked. This excessive curve often develops from muscular imbalances. Typically, the hip flexors and lower back muscles become tight and dominant, while the glutes and deep core muscles become weak or underreactive. Over time, this imbalance pulls the spine into a deep arch. Common causes include prolonged sitting, poor posture, weak core, and glute muscles. Excessive lordosis can lead to discomfort. It could also lead to muscle fatigue and decreased stability. The goal of treatment is to restore balance by strengthening the glutes and core, improving hip mobility, and teaching the body how to maintain a neutral spine. Now, this picture here shows what an anterior pelvic tilt is. It is a postural pattern where the front of the pelvis rotates downward and the back of the pelvis lifts upward. When this happens, the pelvis tips forward like a bowl spilling water. This tilt increases the arch in the lower back, which is why anterior pelvic tilt and lumbar lordosis often show up together. This posture usually results from muscle imbalances. The hip flexors like the iliopsoas and rectus femoris become tight and shorten from long periods of sitting or inactivity. At the same time, the glute muscles and deep abdominal stabilizers become weakened or underreactive. These opposing forces pull the pelvis into forward tilt positions. Anterior pelvic tilt can affect movement efficiency, core stability, and spinal alignment. People may experience low back tightness, hip stiffness, or difficulty activating their glutes. Correcting this posture involves strengthening the glutes and deep core, stretching the hip flexors, and retraining the pelvis to stay in a neutral, balanced position during daily activities. Hi, it's Eileen. In this video, I'll be walking through a full posture analysis using my own photos. I will be talking about lumbar lordosis and anterior pelvic tilt. Right here, you can see Hope standing, and I will be showing you her posture and what is wrong with it and how we could help it and better it. This is an example of lumbar lordosis. I will be explaining what they look like in the body, what's happening with the pelvis and spine, the typical muscle imbalances that contribute to this posture, common pain patterns people experience, and the exercises and stretches that are most effective for correcting or improving it. I will also be talking about the anterior pelvic tilt, which you can see in this picture. Let's start with looking at her side view. In this picture, you can see the lower back curves inward more than what we do consider natural alignment. This exaggerated inward curve is known as lumbar lordosis. Right below the lumbar spine is the pelvis. Here you notice that the top of the pelvis tilts forward, and the bottom of the pelvis tilts backwards. This forward rotation is called anterior pelvic tilt. When the pelvis tips forward, the hip joints move into slight flexion, and the trunk leans slightly backward to compensate. That's why in this picture you can also notice that her ribcage is positioned slightly behind her pelvis instead of stacked directly on top of it. Now looking at the front and back views, you can see how the pelvic positioning affects the rest of her body. Her hands rest a bit behind the hips, which is a giveaway that the pelvis is rotated forward. You can also see a subtle widening of the front of the hips and a small increase in lumbar curvature even from the back view. So what actually causes the shape in the spine and pelvis? In anterior pelvic tilt, the pelvis rotates forward in the sagittal plane. When this happens, the hip flexors pull the pelvis down in the front and the lumbar extensors pull it upward in the back. This combination increases lumbar extension, which is why the lower back appears more arched. The pelvis no longer sits in a neutral position, meaning the ASIS and PSIS aren't level, and the spine compensates with extra curvature. This creates a posture pattern known as lower cross syndrome, which describes the predictable pattern of tightness in some muscle groups and weakness in others. Now let's talk about the muscle imbalances involved. In this posture, several muscles tend to be tight or shortened, and several tend to be weak or lengthened. Now let's go through each group. Hip flexors, especially the psoas, which attach from the lumbar spine to the femur, rectus femoris, which pulls the pelvis downward in the front, and the erector spinae group, which pulls the pelvis upward in the back. All these muscles are tight or overreactive muscles. Now for weak or lengthened muscle, an example is the gluteus maximus, usually lengthened and underreactive. This muscle is responsible for hip extension and pelvic control. Hamstrings as well, as you can see bicep femoris, semitendinosus, and semimembranosus, often relatively lengthened or weak. Sometimes people feel them as tight. Lastly are core stabilizers, especially the transverse abdominis and internal obliques, which help maintain abdominal pressure. These imbalances can create predictable pain patterns, especially in the lower back and hips. She was complaining about getting tired when standing too long, or always feeling tight in the front of her hip. These are examples of exercises that help strengthen these muscles. Here she is seen doing a band hip extension to strengthen posterior chain and external rotators. The goal of treatment are lengthening the tight muscles, strengthening the weak muscles, and retain pelvic neutral and core control. Now she is seeing what is called the dead bugs. This is a core workout that emphasizes transverse abdominis activation. Here she is seen doing glute bridges. This is because in an anterior pelvic tilt, the glutes are often underreactive and lengthened. Strong glutes will pull the pelvis back into neutral, reducing the excessive arch. And when you squeeze the glutes at the top of the bridge, you could create a posterior pelvic tilt, which is the opposite of an anterior pelvic tilt. So overall, using these photos gives a really clear example of what lumbar lordosis and anterior pelvic tilt look like in a real person standing naturally. Understanding the biomechanics, muscle imbalances, pain patterns, and corrective strategy is essential for both assessment and treatment. Thank you for watching, and I hope this helps understand the postural patterns in a much clearer way.